Hello everyone, I'm Rafael Madero. I'm one of the chief residents at Mount Sinai Morningside West, and I'm going to talk to you a little bit about hypercalcemia of malignancy as part of our HEMONC emergencies curriculum. So we're going to start by the definition. Hypercalcemia of malignancy normally talks about ionized calcium above 1.29, though remember this should only be measured in an inpatient setting because it's affected by pH. If measuring total calcium, which is what's mostly used, it is important to correct for hypoalbuminemia. So here's a formula to correct for albumin is 0.8 times 4 minus the serum albumin plus serum calcium. And with a corrected hypercalcemia of 10.5 to 11.9, normally we refer that as to that as mild hypercalcemia. Moderate hypercalcemia would be 12 to 13.9, and severe hypercalcemia would be above 14. Now, in terms of symptoms, besides the total number of calcium, we also look at the rate at which the calcium is increasing. That can also guide our management as well. These are some of the types of hypercalcemia that are associated with cancer. So I like this table. It's from an NEJM article, and it tells you the different types of tumor that cause hypercalcemia, how they cause it, and the frequency at which they're found. So you can see that with local osteolytic hypercalcemia, these are secondary to bone metastases. Normally they cause 20% of the hypercalcemia associated with cancer, and it has to do with, cytokines, PTHRP, local destruction of bones, and like the cytokines basically stimulate bone resorption. And some of the typical tumors that cause this is breast cancer, multiple myeloma, and even lymphoma. Of note, prostate cancer very rarely causes hypercalcemia, so it's not just a matter of having bone metastasis, which prostate cancer normally causes, but like I said, it has another pathological process as well. In terms of humoral hypercalcemia of malignancy, the causal agent is PTHRP. So you don't need metastasis for this. It's the most common type of hypercalcemia associated with cancer, about 80%. And normally you see it in squamous cell carcinomas, though you can also see it in renal cancer, ovarian cancer, endometrial cancer, and even breast cancer sometimes. And another cause is lymphomas it's mostly lymphomas, yes, that produce 125 hydroxy vitamin D. And lastly, there are some tumors that actually ectopically produce hyperparathyroidism, though, these last two causes are pretty rare. And another comment I would like to make here is that, as you know, most of the hypercalcemia you'll find incidentally in the outpatient setting is going to be caused by primary hyperparathyroidism. If you incidentally find it in a sick patient in the hospital, that should raise caution or concern for potentially having hypercalcemia of malignancy as opposed to primary hyperparathyroidism. Now, in terms of why it is important, well, the symptoms are not always obvious, so it is harder to detect. Delayed recognition can worsen morbidity and mortality, and it can also be a marker of poor prognosis. Some studies have even mentioned that after starting to present hypercalcemia malignancy, the prognosis can be at around 3 months. Of course, this depends on the type of tumor, the mechanism, but it can be a marker of poor prognosis is the important point. Also, some of the newer chemotherapy agents that affect osteoblast activity can or could potentially affect the incidence of hypercalcemia. There might be a rise, so more studies are needed to actually prove this. New NEJM article came out in 2022 that might be worth reading. In terms of clinical presentation, you have the classic bones, stones, moans, and groans. So bone pain, kidney stones, belly pain since it affects GI motility, and it can also cause altered mental status up to and including somnolence, coma. But psychiatric symptoms are the most common one though, and it can also even cause cardiac arrhythmias and muscle weakness. Some risk factors, so it is most commonly found with lung cancer, multiple myeloma, renal cell carcinoma. So the type of cancer definitely affects the risk. Breast cancer and colorectal cancer can also cause it, and of course it is more common in advanced disease, hence why it is tied with a poor prognosis. As part of the workup, just confirm it by a laboratory, measure it more than once, and correct it with albumin. Um, and yes, just remember that pH affects ionized calcium. You can measure phos, PTH, PTHRP, 25-hydroxy vitamin D to detect for hypervitaminosis, and 125-hydroxy vitamin D to help establish the etiology. This last one would be more commonly caused by lymphomas. So sarcoidosis can also cause it by a similar mechanism. If the etiology is still not found, you can work up for multiple myeloma or vitamin A toxicity. So I created this table to go over the basics of management. So the mainstays of management in hypercalcemia, before we get into the table, are increasing calcium excretion, decreasing bone resorption, and also treatment of the malignancy. So in terms of increasing the calciuresis, and it's the initial monotherapy for mild to moderate hypercalcemia. So you have isotonic saline. Just be careful in patients with heart failure, though you can use Lasix in those specific cases to be able to hydrate the patient first and get a euvolemic status while still being mindful of that, preventing fluid overload. If the symptoms are severe or moderate and symptomatic, then you can start with 200 to 300 cc's per hour, and then just be mindful of measuring the ins and outs. You want to aim for urine output of around 100 to 150 cc's per hour. In terms of targeting the increased bone resorption, so you have bisphosphonates, mostly zoledronic acid is used, then you have denosumab as well, and calcitonin. So bisphosphonates, the onset of action starts between 2 to 4 days. Zoledronic acid is the one we use more frequently, either IV or subcutaneous. And the thing is, since it takes these 2 to 4 days to work, we usually start with calcitonin. Calcitonin is very fast acting. The only issue with calcitonin is that there's tachyphylaxis. So you develop resistance after 2 days, but it's good to use it right after administering bisphosphonates because it can help you manage the hypercalcemia for those 2 days before the bisphosphonates kick in. And the good thing about denosumab and the situation where we use it is in renal impairment, because bisphosphonates cannot be used with renal impairment. And in terms of increased 125 hydroxyvitamin D production in lymphomas, which causes increased absorption of calcium, you can use steroids. Even prednisone 20 to 40 milligrams per day. And in some cases now they're starting to find that there might be a combined mechanism. So you can have increased PTHRP with increased production of 125 hydroxyvitamin D. So steroids could potentially be useful in these settings where the calcium is resistant to purely bisphosphonates use. And with increased PTH production, you have calcitonin as well. So you can use 4 units per kilogram sub-Q every 12 hours for 48 hours, since, like I said, it causes tachyphylaxis. And hemodialysis is used as a last resort. If refractory to the above therapies, most cases will have decreased calciuresis and increased bone resorption. So like we mentioned, they should be targeted. So some take-home points. Know to look for it. Remember to correct for the albumin. Remember which neoplasms are high risk. Remember that the mainstays of treatment are hydration, decreasing bone resorption, and treatment of malignancy. And I hope this was useful for all of you. Feel free to reach out to me if you have any questions. Thank you.